what are the oral oncolytics? How do you use them in the sense of first line, relapse, refractory drugs, maintenance therapy? Give me some names and let's go through them.
So the most clear-cut and the most widely used category and class of drugs are the immunomodulatory drugs, the IMiDs, and those include an older drug called thalidomide, which was the drug given...
Can we stop right there? Thalidomide. I can hear people's heads exploding of a certain age. Because back in the 60s, that was a drug of ill repute.
This was a drug that was accidentally found to work for multiple myeloma. And it was a drug used for women who had nausea with pregnancy, and as we all know, the babies came out with severe deformities.
It was teratogenic.
Limb deformities. It was extremely teratogenic. So that drug was the first IMiD used for multiple myeloma. Later on, lenalidomide was approved, or Revlimid, and then we have a more potent version of lenalidomide, pomalidomide, which is the third IMiD and the newest IMiD that was used. Another category of drugs is a new oral proteasome inhibitor, which is a descendant of bortezomib or Velcade, which is the injection. So that one is Ninlaro or ixazomib. And we also have an oral histone deacetylase inhibitor called panabinostat or Faradac.
Okay, now I heard at least one MIB in there. So some of these oral agents are actually biologics, right?
Yeah.
Wow.
Exactly.
Oral acting biologics.
Yeah.
This is all exciting stuff.
This is all exciting. And they are used throughout the entire course of treatment.
So you use them to induce, you use them to maintain, you use them for relapse. Yes. Can you just sort of quickly run down which drugs are used for what?
The IMiDs, the Revlimid and the pomalidomide are, for the most part, a backbone of almost every treatment regimen. So they are part of induction. There's lenalidomide maintenance, and then in the relapse setting, almost all regimens involve an IMiD, and the rest of the drugs are kind of add-ons to the IMiD backbone.
So let's talk about safety. Let's talk about, I guess, convenience, efficacy. How do the oral oncolytics compare to the older parenteral drugs in terms of all of this? Are they safer, less safe, the same, what?
Well, the newer drugs are targeted therapies, but they're used in combination, right? So we use NCCN as the guideline, and for drug therapies, NCCN is continually updated. I went back to look at what we were using for training in October, and it's changed just in 4 months. What category
Just when you thought it was
A1
safe to
will
go
be.
back in the water. Huh?
Right. But lenalidomide is, it continues to be category 1A, so we use lenalidomide in combination for maintenance as well as some of the primary therapies.
Given that you can use them together, given that this is not binary, what are the advantages and disadvantages of the oral agents versus the parenteral agents?
So the obvious one is convenience, right? When you're a cancer patient who has a chronic disease, do you really want to be coming in to your physician's office once a week, every other week, once a month even for an infusion? No. So they offer the advantage of convenience. They can be taken at home, which also presents a whole set of issues in itself, because you have to make sure the patients are taking it correctly. You have to make sure the blood counts don't drop. You have a little bit less supervision.
I was about to say that one of the advantages is the inconvenience of the parenterals, which is you've got to show up, right? Someone's got to look at you. Yeah. Someone's got to probably, if they're going to give it to you IV, get some blood and check your white count and check a whole bunch of other stuff. So you're out there in the ozone a bit on the orals, aren't you?
Yes, absolutely. And in the first couple cycles, we tend to keep a closer eye on patients. But the other disadvantage, and people often think, oh, I'm taking a pill, it's going to be less toxic. No, that's not necessarily the case.
Nice try with that one.
Sometimes you see cumulative toxicities such as cytopenias because they're daily or weekly dosing and you get more cytopenias. Sometimes you have more GI toxicities because they're orally absorbed. So certainly they offer an advantage. They don't always offer less side effects.
What did patients, I'm sorry, go ahead.
And I think it's also good to note that the majority of our patients are outside of maintenance, they are on infused therapies as well as the oral therapies. Right?
Exactly.
It's in
Almost.
combination.
If they've got to come in anyway, there's no, unless I'm misreading this, there's no real convenience issue. I guess your choice at that point, if you're going to use both, is efficacy. In other words, is it better to use them together? What do the patients like better? Do they like coming in, or do they like staying home and taking pills?
Honestly, they've done studies on this, and the quality of life is not better for patients who take all orals. In patient-reported outcomes studies where they've looked at patient-reported outcomes, there's not always a benefit to staying on all oral pills. Some people work, some people, can't get to the office because they rely on their son or their daughter to drive them in. And for those people, hands down, they prefer all oral. But
yeah, I think overall it's a challenge for our patients. As Dr. Byrne said, this is a chronic illness that our patients have, and they're living years and decades with this disease, and they're cycling through many therapies. So understanding what therapy they're on, how the cycle will work, how the oral may work in conjunction with that is really important. And I think the other thing to note is our patients, sometimes the therapy depends on how old our patient is, how frail our patient may be. Average age of our patient is somewhere between, say, 65 and 74. It's rare. It's less than 1% of the time that we have a patient less than 50 years of age.
Okay. But from the perspective of the patient then, if I hear you correctly, the obvious advantage is I can stay home and take my pills. I don't have to go to the doctor's office as often. I don't have to get stuck. I don't need an IV infusion for hours. I'm assuming they take an hour or 2 or 3 or whatever.
Yeah, absolutely.
Right? But in contradistinction, you don't get seen. You're not going to get something picked up that a doctor or a nurse or a doctor's extender might see that a patient at home might not. So there is a trade-off here, right?
Yeah, and to me, the biggest trade-off is cost. I mean, I think it's incredible that we have, even now, an all-triplet oral regimen. Ixazomib, lenalidomide, and dex, for example. A triplet-based therapy that's all oral. That's amazing that you can treat somebody for cancer with pills. But I think cost is a big problem because patients have a very, very high out-of-pocket cost, and not all patients can afford.